Next, I'd like to introduce Dr. Vedran Premuzic, who's going to come and talk about AKI and the Neurosurgical Unit.
Thank you, Danielle, for the nice introduction and for the right pronunciation of my surname. I really appreciate it.
I've been practicing.
Thank you, Robbie, for the nice invitation. It's a real pleasure to be here once again. So today I'm going to speak about you just need to help me with the, oh yeah,
Green.
I got managed. So today I'm going to speak about the results we have recently published in cooperation with my good friend Kanush over there regarding the incidence of AKI and the incidence of AKD in neurosurgical patients. So as a critical care nephrologist, I need to manage around 10 different ICUs in my daily practice. So having known the fact that we have the least number of patients we are treating by CRT in neurosurgical unit, that was kind of interesting for the starters. And having discussing with the anesthesiologist, what are the possible reasons for this low incidence of AKI and the low incidence for CRT procedures, we come to develop a hypothesis, firstly, to see the differences between the different anesthetics, and then to see how big is actually the percentage of patients who developed AKI after neurosurgical procedure, and how big is the percentage with the patients with AKD. As you well know, there are many papers who have described the differences in development of AKI in different conditions, especially comparing propofol versus sevoflurane. So in patients after lung transplantation surgery, there is a big difference in percentage of patients who have developed actually AKI after administration of sevoflurane. And it is characterized by the increased levels of plasma renin. It is characterized by the decrease in the urine output, and it is characterized by the increase in sodium excretion in comparison with propofol. So the meta-analysis, which analyzed the differences in patients who were treated after volatile, who developed AKI after volatile or intravenous anesthesia, showed that the patients with intravenous propofol anesthesia is associated with lower incidence of AKI when compared with volatile anesthesia. But when you analyze some papers on animal models, you can see, or even papers on adult patients, you can see that not all the studies have found that significance. So an additional part of our study, we try to analyze what are the variables which are contributing to the development of AKI after sevoflurane. And it's the same for development of CKD in patients when compared different anesthetics. So when you have a patient who is developing AKI in neurocritical care, the development can be associated with many variables. For example, it can be associated with prolonged hypertension, or it can be associated with prolonged lower levels of blood pressure or mean arterial pressure levels after surgery. Or it can be associated with the administration of hypertonic salines, or even by development of rhabdomyolysis in these patients. And it works in both ways, of course, as well as the other organ crosstalk. So when you develop AKI, the starting with dialysis has its own complications. And if this patient is susceptible to acute injury from starters, for example, developing sepsis or developing multi-organ failure, his condition can be even worsened. So what about intraoperative hypertension? Is it associated with even with AKD? Of course. So there are papers who have showed that not only AKI, but also the AKD can be influenced by the prolonged intraoperative hypertension. And the incidence, risk factors, and outcomes can be modified by different variables in neurosurgical patients. So even the blood loss during the operation, or for example, the prolonged hypertensive episodes, can be developing AKI in this group of patients. And if your patient having a neurosurgical procedure is developing AKI, and especially when comparing different stages of AKI, it can significantly impact not only the recovery of kidneys, but also his overall survival in the ICU. Even in the patients are divided by trauma or non-trauma. The patients who have developed higher levels of AKI had a shorter survival when compared to the patients with the lower AKI levels. But there are not that many studies regarding AKD, especially in neurosurgical patients. So the additional idea was to analyze what is the percentage of these patients after developing AKI after neurosurgical procedure. So we thought at the beginning that it's going to be easy. We're going to collect some number of patients, but that number of patients actually increased a lot. So we have analyzed more than 6,000 patients, and the incidence of the patients who have developed various stages of AKI. And we have categorized these patients depending by the type of operative procedure. For example, we had patients who had aneurysmal or arteriovenous vascular malformation vascular surgery. The second group was patients with the surgery for subdural hematoma and the patients with craniotomy for tumor. We use propofol in group of patients with aneurysmal, arteriovenous vascular malformation, and craniotomy for tumors. In the rest of the patients, sevoflurane was used specifically for patients with subdural hematoma or for urgent operations. And we were actually right. The percentage of patients who would develop AKI after neurosurgical procedure was not that high. But when we have divided these patients regarding different stages of AKI, different severity of AKI, we have found that patients with prior comorbidities, for example, patients with diabetes, or patients with prior coronary heart disease, or even patients with prolonged hypertensive episodes, those patients were in a subgroup who had developed more severe AKI, although we have not found a difference in survival between these subgroup of patients. And when we analyze the patients who have developed AKD, we have found the development of AKD in almost 9% of patients. And similarly to the patients who have developed AKI, we have found exactly the same variables: prolonged hypertensive episodes and prior comorbidities like diabetes or coronary heart disease. Interestingly, in contrast to the patients who have developed AKI, the patients with AKD had a shorter survival compared to the patients without development of AKD. And when we have done rough curves, and you have heard Raj telling us this morning that we should abandon rough curves, but nevertheless, I'm going to show you the graphs. Sevoflurane was a significant independent variable which affected patients and which was strongly and significantly associated with development of AKI and AKD. Almost statistically significantly was the hypertensive episodes during surgery. So having said that, and having in mind the fact that patients on sevoflurane had an increased odds ratio of 5.09 for AKI development, what are the potential reasons for these observations? They can include the toxic neurogenic moderate effects of sevoflurane on kidneys, which we know, which were described in the previous studies. And once again, emphasizing the fact that hypertension during the operation was more common among patients with both high and low AKI stages. Apparently, not every kidney is going to be affected by sevoflurane. We know that. We know that from animal studies. We know that from human studies. But these kidneys can be susceptible to drug-related injury as well as our patients in our study. And that can be extrapolated to the other subgroups of AKI patients from the other different ICUs and different etiologies of development of AKI, because our patients had increased risk for AKI like diabetes, coronary heart disease, and hypertension during the operation. That can actually increase the risk of drug toxicity. And this may motivate choosing propofol-based anesthesia in patients with increased risk of postoperative AKI due to pre-existing high risk of renal ischemia. Our ICU patients treated with balanced anesthesia with sevoflurane for the neurosurgical operations had more frequent AKI, had more frequent AKD at the end of the ICU stay. And interestingly, they had a shorter survival than patients without AKD. It had an even stronger association with higher mortality than AKI development in our group of patients with hazard ratio of 4.96. And with that, I'm going to save some time and conclude the lecture. Thank you.
I'll take one question.
You're in the hot seat. Stay up here.
So, any question from the audience?
Okay.
Oh, he's formally putting on his jacket to ask the question.
Okay.
Yeah.
Professor Premuzic, really nice talk, Vedran. Regarding the pathophysiology of the lesion against the kidney, you have with sevoflurane, either fluoride is produced. Normally, it's gonna induce nephrogenic diabetes insipidus. And then you have compound A, which is produced as well. Compound A will touch the glomeruli, touch the proximal tubule, and touch the distal tubule. And this is going to be probably make a destruction forever of this kidney and this part of the kidney. So in your mind and in your study, very nice study, which compounds, either fluoride or compound A, in your mind was responsible of the lesion you were seeing?
Thank you, Patrick, for the question. I would say compound A. I think that the glomerular tubules will be mostly affected, although the fluoride will be metabolized mostly in the liver at the beginning. But I would say that the kidney which is susceptible to that, especially with the prolonged decrease of perfusion of the kidneys during the operation and after the operation, would be mostly affected and mostly susceptible to the drug injury. It actually depends on the amount of time which will be exposed to that. That will be approximately the culprit for later CKD, AKD, CKD, or God forbid, end-stage renal disease. I would say, yeah, I would say that.
Okay, thanks a lot.
Okay, please, quick question, please.
This is Jonathan Meg, Sydney. Sevoflurane, isoflurane, and all those fluranes have been shown to protect against AKI in various models of injury, and they do so by effects on the NF-kappa B, at least in part. Most of the operations you're doing, were the patients administered the sevoflurane before the procedure, and if so, for how long do you think? Because it's been shown that if you get pre-exposure, you get it. It's less clear-cut what happens if you get it at induction.
Yeah. That's the reason I said today it's really debatable regarding the effect of sevoflurane on AKI, because we still have some data which are showing that it has a protective effect. Still, the studies are showing that there are a large amount of patients who are susceptible to development of AKI, and I would say yes, the preconditioning with sevoflurane would be one of the main reasons.
Okay, thank you very much, Vedran. Nice talk.